SIDS affects infants less than a year old, with ages up to 4 months being particularly vulnerable. If the baby is sleeping in the bed with someone else, it increases the risk for SIDS or accidental suffocation. Now they can sleep in the same room with someone else beside the bed, just not in the bed. Nothing else in the sleep area. Remove all play items and soft objects from the crib at sleep time, and that includes bumper pads. Place baby on a firm, safety-approved crib mattress. Avoid overdressing your baby or setting the thermostat too high. And when it comes to sleeping, always, always, always place baby on his or her back. And get some rest, because you're gonna need it.
You don't know me. Probably never will.
But I need you to do something for me.
Something that could literally
Change everything.
You'll never get a thank you card, and yet I need you to do it.
And if that weren't enough, I need you to do it as soon as you are able to.
If you do this for me,
I'll do it for you. And for every single person you love.
Deal?
This is our shot to leave COVID behind.
Great morning, everyone, and thank you for joining us on today. Representing the CCRM Fertility, Northern Virginia, joining with us as our speaker for today, Dr. Carter Owen. Let's receive her virtually now as she comes.
Hey guys, I'm so happy to be here today. Thank you for joining. I'm Dr. Carter Owen. As he said, I work at CCRM Northern Virginia. We're a fertility clinic over in the Tysons area. I am excited to talk to you guys today about LGBTQ plus family building, give you some sort of nuts and bolts of what you need to understand and some of the options available. And I'd like to share with you guys kind of right at the start. So I have a wife. We have 2 boys that we were able to conceive using donor sperm IUI. And I'm really excited to tell you guys how to build your family too. So to start things off, I think the first thing that we need to start with the basics. So in order to make a baby, we need eggs, sperm, and a hospitable uterus at minimum. And then if we're going to do it using an individual who has a uterus and has their own egg, then we also need open fallopian tubes. So when we go through the talk, we're going to talk about each of those systems individually, and we're going to talk about how we understand what we need to know about each one. So let's start with eggs. So for individuals who have eggs, it's important to understand that age matters. You were born with all the eggs you were ever going to have. They were set ready to go actually before you were even born. You had the most eggs when you were a 20-week fetus, and you are losing eggs all the time. You had about 20 million eggs when you were a 20-week fetus. You had about 4 million when you were born, about 450,000 at puberty, and then all the eggs will be gone at menopause. And our reproductive lifespan is between puberty and menopause for those of us who have ovaries. When we do testing to try to understand what's going on with the ovaries and with the egg count, we can look at quantity. We have testing for quantity, but we don't have a way to test quality. Quality really is your date of birth. And I'll show you a little bit of an intimidating picture here, but this is the effect of age as on the egg and quality of the embryos. So you can see here that these are people going through IVF, and at the age of 38, if we were to biopsy embryos and count chromosomes within those embryos, about 50% of the embryos are going to have a normal chromosome count represented by the dark bar, and about 50% of those embryos are going to have an abnormal chromosome count represented by the light gray. You can see that after 38, the light gray representing abnormal, and these are things like Down syndrome that you may be familiar with, so disorders of missing or added chromosomes, that light gray bar goes nuts. So again, age really matters. So for those of us with ovaries, the sooner we want to have children, the better, because of the diminishing quality of the eggs, and then also, like I said, diminishing quantity. In terms of quantity, we have some tests for that. So basically, let me show you another chart here. We bring you in typically in relation to the menstrual cycle, usually cycle day 2, 3, or 4. Your first day of bleeding, we call cycle day 1. And every month, we all have a group of follicles that we bring up from our reservoir. Here's my imaginary reservoir. How many you put in this group, we call that the antral follicle count, each follicle having 1 egg. How many you put in this group is reflective of how big your reservoir is. We also look at how loud does the brain talk to the ovary to tell it to do its job. And there is a fierce competition among these antral follicles to be the one that's going to win and be the one we ovulate. So when we are young and fertile, that follicle stimulating hormone should be whispering to promote that competition. And as we get closer to menopause, that follicle stimulating hormone is going to start to really shout. And so we'll see that FSH level go up. The other way we can know, so we said antral follicle count, we'd like to see at least 10. I should have said that. Follicle stimulating hormone, we'd like to see that less than 10, whispering again. And then I also have a direct marker, AMH, which is a reservoir marker. I'd like that to be over 1. That's a blood test. And by those 3 measures, we're going to evaluate ovarian reserve. And understanding someone's ovarian reserve tells me a couple things. It tells me kind of how much time you have to try to achieve your pregnancy, but it also tells me how you might respond to therapy. On the sperm side of things, we need to do a semen analysis. So for individuals who have testicles and make sperm, it's important to understand that you started making sperm at puberty, and you will make sperm till you die. For those of us who have ovaries, it's not fair because individuals with testicles can have babies forever, but those of us with ovaries have a finite reproductive lifespan. For the semen analysis, it's very rudimentary. So we're gonna have a fresh collection of sperm. It'll go to our andrology lab, and they're gonna look at the volume of the ejaculate. They're gonna look at the concentration of the sperm, how many million per milliliter. They're gonna look at percent swimming, we call that motility. They're gonna look at percent morphology, which means the percent that appear normal. And then we have normal values for those, and we try to understand how many sperm we have to work with. How many sperm we have to work with, what percent is swimming, all those things matter. And that helps us understand what therapies we might be able to use. For individuals who have testicles that are transitioning to female and are taking estrogen, it's really important to understand that taking estrogen will shut down the production of the sperm. So I talked about how follicle stimulating hormone is the signal from the brain to the ovary to tell it to go through a cycle. It is also the signal along with luteinizing hormone, same for the ovary too. So FSH and LH, those are the 2 signals from the brain that talk to both the ovary and the testicle. And when we take hormones, whether that be a birth control pill or whether that be estrogen, like I said, in individuals who are transitioning, it is going to tell the brain, shh, stop talking. And that's how we can prevent pregnancy on the ovary side, but it's also going to stop sperm production on the testicle side. So it's very important that we tell those individuals, if you want to preserve your ability to have children, it's better to freeze sperm ahead of transition. It's not that we can't get sperm production back, but it can take up to 12 months if you've been on this therapy for a long time. And sometimes it never fully recovers, or it recovers a little bit. And then we really have to only talk about IVF as an option in terms of how we achieve a pregnancy. Let me see what's happening in the chat here. Okay, perfect. Just make sure we didn't have questions. And then in terms of, so we've talked about eggs a little bit, we've talked about sperm and some of the testing that we do. So then we need to talk about the uterus. So we need a hospitable uterus to have a pregnancy. In terms of how we determine that, typically on that initial ultrasound for individuals who have ovaries who also have a uterus, we're going to look at the uterine structure with ultrasound. And we're going to kind of scan through, and we're going to make sure the muscle looks healthy. We can tell a little bit about the lining, but we typically need some follow-up testing, like a hysterosalpingogram. That is a fancy medical term that means I'm going to look at the uterus and the fallopian tubes with an x-ray. On that test, we take, let me grab my pen. We take some pictures while we inject dye. So we put you in a position kind of like you're getting a pap smear. So there's a speculum involved. We put a little catheter in the tip of the cervix. We inject dye into the uterine cavity, and we look to see if it looks like it has a normal shape, like a triangle. We watch that dye flow into the fallopian tubes and then hopefully flow out the ends. And that'll prove to us that the cavity looks okay, and that the fallopian tubes look normal and are open. The other test that we can do is a saline sonogram. Saline sonogram is similar, only now instead of x-ray, I'm using ultrasound, and I can't see the tubes. I'm just going to be focusing on the uterine cavity. But we can put a little catheter into the tip of the cervix, inject salt water, and then scan through with ultrasound and get some 3D images to see that cavity looks normal. Some of the things that we might see are like uterine fibroids. So 75% of women have uterine fibroids. African-American women are more predisposed to fibroids, bigger ones and multiple fibroids, and they can be in all different locations. From a fertility perspective, the ones we really care about are the ones that are in the cavity where a baby would be growing, or next to the cavity. These kind that are big and like hanging off the uterus, they don't bother us so much. These still can cause discomfort during pregnancy and be an issue, but in terms of trying to achieve a pregnancy, we're really more worried about the ones that may impact the uterine cavity. So that's some of the testing we can do to determine if you have a hospitable uterus. And then in terms of other testing we might do when you come to see a fertility doctor, we also care about kind of the source of the sperm and the source of the egg, and then genetically when they come together to make a baby. So we often recommend a genetic carrier screen. And I'm going to take you back to high school biology here. This is autosomal recessive inheritance. So big A, little a meets big A, little a, and they go to make a baby. So big A represents a working gene, little a represents a not working gene. And when these two individuals go to have a child, they have a 1 in 4 chance of both passing on that not working gene, the little a's, and having an affected child. And then 3 out of 4 chance they'll pass on the big A, which is the working gene, and all you need is 1 big A to be normal. Some disorders that you'd be familiar with that are inherited in this way are cystic fibrosis, sickle cell disease, thalassemia, Tay-Sachs. There's a whole host of conditions. And on the genetic carrier screening front, there are a bunch of different companies that offer different tests with big panels. We do that blood test, and we try to see, are you a carrier for something? And then the person you're trying to make a baby with, or the sperm source or the egg source you're trying to make a baby with, do you all match up as carriers of the same thing? And we want to try to avoid you trying to, make a baby with someone who's also a carrier of the same thing as you because of that risk. And these are, in general, rare genetic disorders, onset at birth, and generally kind of devastating and chronically debilitating. So we try to help you make the right match. In terms of treatment options when it comes to the LGBTQ plus community, I always start the consults by saying, what's the dream? And what do we have to work with? Do we have eggs? Do we have sperm? Do we have a hospitable uterus? Do we have open fallopian tubes? Who wants to carry? Who doesn't want to carry? Who wants to provide eggs? Who doesn't want to provide eggs? Do we need donor eggs? Do we need donor sperm? Do we need a gestational carrier? There are literally a million different combinations of how we can put this all together to help build the family. And so I always start by asking sort of what's the dream? And then we go about the testing, looking and evaluating each of those individual components and figuring out what's the best way for us to help you build your family. To talk a little bit about some of the nuts and bolts of how the treatments may work. So once we've done the testing, we're going to go through everything and again, make a plan. So in a scenario where we have an individual who has both a hospitable uterus, open fallopian tubes, and working ovaries, we might decide, and doesn't have sperm available, like a same-sex female couple, we would talk about donor sperm IUI. So for that therapy, it could be as simple as an individual tracking their ovulation at home. So let's talk about ovulation for a second. So I talked about how you have a group of follicles. You've got follicle stimulating hormone whispering to that group, fierce competition to pick who's going to be the winner. As that follicle grows, we can see on ultrasound it get bigger. We see the estrogen rise. And when the estrogen reaches a critical threshold, it will signal back to the brain to send down that luteinizing hormone surge. Some of you may have already tried doing ovulation predictor kits at home, and what you are looking for is that LH surge in the urine. And there's lots of products over the counter There's some that are like little strips that you dip in urine. Some of them are a digital monitor with like smiley faces. There's lots of different ways to do this, but you can track when that LH surge happens, and then that can help you time exposure to sperm. So as we go through that, that early part of the menstrual cycle, we've got that follicle growing, estrogen signals, LH says, okay, it's time to ovulate. And then about 36 hours from the start of this surge is when we're going to release the egg. And the sperm needs to be waiting on the egg. That's the general principle. So for those of you who are able to get exposure to sperm at home and don't need the doctor's help, your fertile window is going to be the 6 days that end in the ovulation. So the textbook cycle, like what's represented here, is a 28-day cycle. What varies from person to person and cycle to cycle is how long it takes us to get to ovulation. What's sort of set in stone, with a few exceptions, is a 2-week period from ovulation to either a pregnancy or bleeding again. So you can take however long your cycle is, subtract 14 days. And when I say how long your cycle is, I mean first day of bleeding to first day of bleeding. Again, 28 days is sort of the textbook normal, but some people have a 26-day cycle and some people have a 30-day cycle. So you just take your total number of days, subtract 14, that's the day you ovulate, and then you work backwards. So for a 14-day cycle, it's 14, 13, 12, 11, 10, 9. So cycle day 9 through 14 is the 28-day cycle person's fertile window. And that's when you want to have that exposure to sperm. And the best day is the day right before you ovulate. So with that 28-day cycle, it's going to be cycle day 13. And we have a question, and I'll come back to that. We're going to talk about carrier in a second. All right. So we were talking about IUI. Okay. So you could be at home checking your ovulation predictor kit, call up the doctor's office, or there are midwives in the DMV that provide at-home insemination, just so you know. But however you're going to get exposed to that sperm, you could detect that ovulation, and then the next day is when we would do the IUI. And that's because, again, 36 hours from here to here, and you're going to detect that surge. It'll last for about 24. So we just want to get that sperm there as soon as we're waiting on that egg. And then there's the 2-week wait, and hopefully a pregnancy. When we do the insemination, it's very simple. Medical turkey baster, I joke, a literal and figurative shot in the dark. This is what the catheter looks like. It's thin and flexible. This doesn't hurt. The most uncomfortable part is probably having to have a speculum. The gauntlet for the sperm is the cervical mucus. So we are going to take that catheter and we are going to put it up right above that inner door of that cervix, and we can release the sperm here into the uterine cavity, and then it'll swim to the end of the tube to greet the egg. So after we ovulate, the egg is released into the pelvis, and there's actually a chemical attraction between the end of the fallopian tube and that egg, which is really cool. And that fallopian tube has like finger-like structures. They can grab the egg, and then sperm and the egg meet up here. This is where fertilization occurs. And then that single cell is going to divide multiple times while it travels back to the uterus over the course of 6 to 8 days. And then it's going to come to the uterine cavity and implant and hopefully establish a pregnancy. So again, with insemination, it's typically going to be either partner sperm that we would collect fresh. If your partner's not available, we can freeze it and we can use frozen sperm, or it could be frozen donor sperm. The other option is to get known donor sperm. The frozen sperm typically is going to come from a sperm bank, and there are lots of options for sperm banks. I usually encourage patients to choose kind of from the big four, just to make sure that all the FDA testing has been done. So that's Fairfax Cryobank, that's local, Seattle Sperm Bank, there's California Cryobank, and Cytex. Those are kind of the big four. And they've done a whole bunch of screening, family history, genetic carrier screening. One of the things that'll come up when you're trying to select donor sperm is both genetic carrier screen, but also what's the CMV status. You only need to worry about CMV status if you are doing inseminations. For IVF, it's not as critical, but CMV has to do with whether you have been exposed to cytomegalovirus in the past. Most of us have. Most of us are CMV positive, but your doctor will check and see if you are CMV negative. And if you are CMV negative and have never been exposed to this virus before, you don't want the first time to be when you're exposed to sperm from the sperm bank and also achieving a pregnancy, because CMV is one of those infections that's a no-no in pregnancy. It can cause birth defects, miscarriages, all kinds of bad stuff. So this is something that your doctor will talk to you about and help you select the right sperm. But the main things that you'd be worried about are, do you match up on that carrier screen? And then what's the CMV status so that you can find the right donor? And then after that, it's all the fun stuff. In terms of known donor, obviously not someone related to the egg source, but you might have a friend or a family member of your partner that you're hoping to use their sperm. The main things to keep in mind with that are going to be making sure that person's a good donor, because not everybody is going to be a good sperm donor. And for the purposes of using that sperm in a clinic, we would require a quarantine period, and the sperm would be frozen. That has to do with protecting the individual who's receiving the sperm from infectious disease. And so there's a lot of testing that goes into that, and then that quarantine period. But the frozen sperm, sperm doesn't always freeze well, is the main point to make here. And it takes about 1,000 guys at the sperm bank to find one who's going to be a good sperm donor. And yes, it's more than just semen analysis. It's also family history and carrier screen and all that stuff that they can get weeded out for. But my point is that not everybody makes a good sperm donor. So you may have someone in mind, but they may not turn out to be the right source of sperm for this process. That is also an option. And for those patients, we talk about going, like here locally, we would send them to Fairfax Cryobank to become a known donor for you. And then there's testing that's done, semen analysis, they freeze the sperm into vials, and then those vials come to us and we use them for the inseminations or IVF. So that's kind of the nuts and bolts of how IUI works. The only other thing I didn't say is if the individual who has ovaries doesn't have a regular cycle, there are medications that we can use. You may have heard of Clomid that can help push the ovary to recruit that follicle that we need to release the egg. Oral medications like Clomid and Letrozole is the other one. The main thing to keep in mind is that when those medicines do their thing, they actually tell the brain to talk louder to the group. And when you have more follicle stimulating hormone around, more than one might escape. Remember, the brain's normally whispering. So if the brain starts to yell, there might be enough hormone around for more than one to escape and be a winner. So you might have 2 dominant follicles or 3. And if you start doing math, you're like, wait a second, if I release 2 or 3 eggs and then there's the sperm find 2 or 3 eggs, we're talking about multiples. That's right. So there's about a 4 to 8% chance of multiple pregnancy, usually twins, less than 1% chance of triplets or more when we use that therapy. So we use it with caution and typically with ultrasound monitoring to try to help you understand how many eggs you might release and what's the risk. And obviously the age of the egg source matters too in terms of understanding that risk. And then in terms of other ways that we can build a family, so we've talked about insemination. The other sort of big one is IVF. So IVF stands for in vitro fertilization, and I should have said IUI stands for intrauterine insemination. So again, medical turkey baster. And now we're going to talk about in vitro fertilization, which means eggs and sperm in the lab making a baby. And so whenever we're talking about donor eggs, that would require IVF. But IVF is going to be useful for those of us who are older, those of us in terms of an egg source, those of us who may not have working fallopian tubes or have had surgeries, or for whatever reason our tubes are not working. Those are some main examples. And then for those of us who don't have eggs or a hospitable uterus in our family that we're trying to grow, we'll require donor eggs, IVF process, and then a gestational carrier. So when we do IVF, the general way this works is, I told you again that the brain whispers to the ovary to tell it to go through its job. So when we do IVF, we tell the brain, shh, be quiet. And we give injections. You've probably seen this on TV, but there's injections of LH and FSH that individuals with ovaries can take. And we tell that group, you can all be winners. It's not just one, not just 2 or 3, like the oral medication. We say, everybody march forward. Let's try to get as many eggs as we can. It takes 8 to 10 days of injections to get to that point. And we will be monitoring with ultrasound and estrogen levels, watching the estrogen grow as the follicles grow, and measuring how big they are. And as soon as it's been at least 8 days, the follicles are the right size and the estrogen's the right level, we'll know it's time to trigger. We will use an injection that we call the trigger shot that will mimic that luteinizing hormone surge. We know from the start of that injection to when you release the egg is about 36 hours. And so at 35 hours is when we take you to the operating room for a procedure called an egg retrieval. It takes 10 to 15 minutes. It is a nap. It'll be the best nap you've had since COVID started. Propofol, similar to a colonoscopy. And we put in a transvaginal probe. We have a needle attached. There's a little tunnel on the ultrasound probe to guide the needle. And we do this under ultrasound guidance. We aim it towards the ovary, and your normal lemon-sized ovary is now going to be like a small cantaloupe, large grapefruit, filling up the pelvis. And yes, during this process, when the ovaries get that big, it is uncomfortable. It does not feel good. It can cause some cramping. So basically we're going to aim that needle over, and then we're going to suck all the fluid out of those follicles, and the eggs are going to be free floating in that fluid. That fluid goes through tubing into a vial. We pass the vial through a window to the embryologist. They stand at a microscope. They pour the fluid into a dish, and they go on a literal egg hunt. At the same time, we have our sperm source, whether that be fresh or frozen, and we take the sperm and we combine it with the egg. There's two ways to accomplish that. You can have the sperm swim up to the egg, or you can take an egg and put it right inside. Take a sperm and put it right inside the egg. That's called intracytoplasmic sperm injection, or ICSI. And then embryos are checked for the next day. We check for fertilization. And human reproduction is inefficient at baseline. That's also very important to understand here. That's why I have a job. And it's inefficient in the IVF lab too. So this is kind of a normal drop off. So if we were to extract 10 eggs, and I'm only using 10 because it helps me with percentages, we'd expect about 70 to 80% of the eggs to be what we call mature eggs. And those are ones that can receive the genetics of the sperm. And then about 70 to 80% normally fertilize. So this is 24 hours to get from eggs to how many fertilized embryos. This is a single cell. This last arrow represents about 7 days, 5 to 7 days. And that single cell is going to divide multiple times and become that blastocyst. That's the same embryo we talked about that took 6 to 8 days to travel through the fallopian tube to implant in the uterus. So in the lab, we're watching it become that blastocyst, and now it has 100 to 200 cells. This lump will be the baby, and this ring of cells will be the early placenta. And we can take a 5-cell biopsy, and we can actually count chromosomes. And if you have any other genetic conditions that we're worried about, and here I'm using the example of a high-risk breast cancer gene, it is available to do genetic testing for things like that. But we can also just count the chromosomes. And by counting the chromosomes, we're reducing the risk of miscarriage before we put an embryo back. About 70% of miscarriages are going to be due to that missing or added chromosome problem, which increases as individuals age and try to be pregnant. So we can take that like 1 in 5 risk, sort of overall, it's about 20% of pregnancies end in a miscarriage. So we can take that 20% risk of having a miscarriage, and we can take it down to about 4 to 5% when we do the genetic testing on the embryos. And then at CCRM, we get kind of a report back similar to this. And you can see that we've taken those embryos, we've biopsied them, they're frozen at that point, and then we send off those cells for the testing, and we get a report back like this. And you can see this couple had 3 embryos that were tested as chromosomally normal. And then we can look back to see how beautiful did the embryologist call that embryo at the time of freezing. And then we can tell you what's the percent chance of a live birth, with the highest being about 70% when we go to transfer that embryo. When we transfer the embryo to our hospitable uterus, it takes about 2 weeks to prepare the uterus, and then about another 5.5 days of hormone treatment before the uterus is ready. So again, we're following that normal menstrual cycle here. So there's different ways we can do this. One is to let you go through a natural cycle, and then we transfer the embryo at the right time, and then check a pregnancy test at the end of the month. Or we can control it and tell both the brain and the ovary, don't be quiet, don't talk. And we'll talk directly to the uterus with 2 weeks of estrogen to grow the lining nice and thick. Then we, again, mimicking that natural cycle, give about 5.5 days of progesterone. That's what makes that lining thick and vascular. Transfer the embryo, and then 9 days later, a pregnancy test. So it takes about 1 menstrual cycle to prepare the uterus. Whether we do that in a natural cycle or with medication, takes about 1 menstrual cycle to get to that pregnancy test to transfer the embryo. And in general, once we know that we have a genetically normal embryo, we're going to transfer one at a time. And then the other piece, and I know there's a question about carriers, the other piece is thinking about gestational carriers. And I think the question is about age. Is there an age cutoff to be a carrier for a family? Okay, so we do have guidelines that are provided by the American Society of Reproductive Medicine, and I'm pulling those up. And we use these as guidance. You know, obviously there can be some special exceptions if the person that you choose to be your hospitable uterus is, you know, someone related to you, like a friend or family member. But in general, these are the things we think about. So we obviously want them to have a normal uterus without any, structural abnormalities. We want them to be about 19 to 40 years old. We would like them to have a normal weight, so a BMI less than 30, be a non-smoker, have had at least one child, and no more than 5 deliveries, including no more than 3 C-sections. Obviously have an uncomplicated medical history, have an uncomplicated obstetrical history, like in terms of when they were pregnant. We don't want them to be on any medications that would be harmful in pregnancy. They can't be anybody who's doing any high-risk behaviors that could lead to it being more likely to have infectious disease, like getting tattoos in a non-sterile fashion, high-risk sexual behavior, for instance. They need to have a stable home environment. They need to not be on government assistance. That's in there because we don't want anyone to feel coerced to do this. They need to have transportation. Again, just the idea that no one's feeling coerced to do this. And then typically these people would be in the United States. So again, friend or family member is an option, but there's also agencies that you can work with to identify these people. It usually takes 6 to 12 months to match and to find a carrier. And there's definitely a waiting list, and the agencies are great. They set your expectations at the beginning for how long it'll take for you to match. And then, if this is not someone who's doing this out of the goodness of their heart, it may be $80,000 to $100,000 to pay for medical expenses, compensation, agency fees, et cetera, to be able to pursue using a gestational carrier. The other thing, thinking about third-party reproduction, that's the term we use to describe when the eggs and sperm and uterus don't come from the same people. The other thing to keep in mind is for all of the LGBTQ family building also is, getting in touch with a reproductive attorney. So we have a list of reproductive attorneys that we suggest people talk to, and that's going to be about making sure that you cross your T's and dot your I's in terms of, who are the legal parents, making sure that you protect your child in case, someone falls ill or something like that. That's going to be really important. And especially if you're like pursuing at-home inseminations with like a known donor, especially in Virginia, for instance, there are laws that say that even if that person says they're a donor, they would still be considered the legal father. So very important to talk to a reproductive attorney when you're doing third-party reproduction to make sure you have everything set. And then the other thing I wanted to say was in terms of how do you find donor eggs? So same kind of thing with your gestational carrier. So the donor eggs could come from a friend or family member, ideally someone less than about 37 because of the effects of age, like I showed you. Ideally a non-smoker and someone who would be safe to go through that IVF process because they would come and be our patient. They would undergo stimulation like we talked about. They would have that egg retrieval procedure. And then those eggs would then be inseminated with the sperm to create the embryos. And then those embryos would go back into the hospitable uterus. So it could be a friend or family member. It could be someone who's not known to you now that you would identify through an agency again. Some agencies do both donor egg and gestational carrier. Some do only donor egg. Some do only gestational carrier. So that's something that we can help you with. But there is the possibility of identifying this fresh egg donor. And the advantages of a fresh egg donor, whether that be a friend or family member or this young person that you maybe have never met before, who you identify through an agency, the advantage is that you get more eggs. And just to kind of give you a number to think about. So if I got 20 fresh eggs from a donor, there's about a 94% chance of at least one live birth. And there's a very high chance that from 20 eggs, we're going to have the opportunity for siblings. The other option that's the fastest and the cheapest is going to be a frozen egg bank, similar to a frozen sperm bank. So with a frozen egg bank, we can have groups of eggs. We call them cohorts. There's about 6 to 8 donor eggs in each cohort, and you can buy a cohort of eggs. They are shipped to the clinic. They are thawed, inseminated with sperm of choice, and then embryos created, and then embryos into the hospitable uterus. So that's kind of the nuts and bolts of how the donor egg process works, whether it be fresh or frozen. And you can overcome the limitations of the frozen egg bank in terms of starting with a smaller number of eggs by buying more than one cohort. So maybe instead of 6 to 8 eggs, you buy 16 eggs, and you'll start to have more of an opportunity for the siblings, et cetera. And then the other thing that we talk about when it comes to third-party reproduction is counseling. And this is not meant to determine whether someone's going to be a good parent. This really is about origins. How do you explain origins to your child? And my wife and I have this book that was recommended to us that I love that's called What Makes a Baby? It's by Corey Silverberg. I always have to pause and think about it because one time I had a couple in my office and I Googled how to make a baby. And I can tell you that from Google, that is very inappropriate. So What Makes a Baby is the name of this book. And it's wonderful. It talks about it just the way I'm talking about it. You know, some people have eggs, some people have sperm, some people have a uterus. And these are the things we need to make a baby. And it's very asexual in the drawings, and it's a really cool children's book. So I recommend that to everybody. But again, this counseling session is really meant to highlight, how we explain origins to our children, where'd they come from. And I know you all know this, but in general, this day and age, probably best not to try to keep secrets. Never goes well. So with that, I think we've covered just about everything. And obviously, if y'all come for a consult, we'll go through everything in detail again, and we'll make sure that we have, we cover everything. And like I said, it's always sort of like, what do y'all bring to the table and what do we need? And we figure it out. How do you counsel families when it comes to financing the treatment? Yeah, so we have a whole financial counseling team. Depending on what is required, there may be more cost involved. So like I said, if you're a couple, like a same-sex male couple that has sperm but doesn't have an egg and doesn't have a uterus, you're going to need donor eggs and you're going to need that hospitable uterus, a gestational carrier, and that can be very, very expensive. So a lot of times you have to make plans to save up. I've got friends who've done GoFundMes to help with financing this. Again, that friend or family member who may be able to contribute is going to decrease the cost significantly, but we have a whole financial counseling team that can help. We talked about the age cutoff to be a carrier for a family, so typically about 19 to 40 years old, but there can be some exceptions if it's a friend or family member and we medically review it and deem that person safe to carry. Clomid is not always recommended. The question is Clomid always recommended when doing an initial IUI? No, like I said, you could do a natural cycle as long as you're having a natural menstrual cycle. And in fact, I almost never use Clomid because the side effects are so sort of debilitating. It can make you feel pretty hormonal and a little bit crazy. It can give headaches and hot flashes and just and in the worst circumstance can even cause a visual disturbance that isn't always reversible. So I usually use letrozole, which works in a similar fashion, has fewer side effects, but we would only use that if we needed it. And that would be an individual decision that we would make together. The next question is, if you smoked in the past, like 10 to 12 years ago, are you ineligible? I'm wondering if this question is coming from the same person asking about being a carrier, and the effects of smoking are reversible. So in my mind, I do not think you would be deemed ineligible if you had been a prior smoker, as long as you are no longer a smoker. Yeah, same person. Okay, perfect. Yeah. So yeah, you wouldn't, I'm glad you're now a non-smoker. That is, that's very good for your health. But yeah, you'd be fine. I'm happy to answer other questions if y'all have them. Or if there's anything I didn't cover that y'all hoped I would. I know I was talking fast, but I think this video is going to be available and y'all can slow me down and listen to it later. And obviously, we'd be happy to see you at CCRM Northern Virginia for a consult to help you grow your family. No other questions for now. All right, perfect. Another question is age the primary factor for success? So that's a great question. And when we're talking about the age of the egg, the answer, it's yes. It's more complicated than that. Again, I have a job because human reproduction is inefficient, and whenever we introduce new inefficiencies into the system, it can become really hard to have a baby, and that's when you need the help of a reproductive endocrinologist and fertility doctor. But if all things are fine and the only thing we're dealing with is age will become the primary factor for success. And that's why I tell everybody, I mean, as soon as you determine that you are interested in growing your family, it's the right time to start thinking about it. Come see a doctor if you need to. But yes, it's the sooner the better. In our culture, I also have a job because a lot of us focus on career first and put off family building, and age matters. Age matters a lot for the egg source. The other thing that I didn't mention, I talked about people who are transitioning from male to female and the effect on the sperm. I didn't talk about the opposite. So if you're an individual with ovaries and you are on testosterone treatment and you are transitioning to male, we don't have a lot of great data right now about what's the long-term effect on the egg quantity or quality. Age still matters in that scenario. But the way I think about it is being on testosterone is similar to taking a birth control pill. And I see people every day who've been on birth control pill for 10, 20 years, and they do fine as soon as we take away that birth control pill. Again, what those hormones are doing is they are telling the brain to be quiet, and it's kind of putting the ovary in hibernation mode. I told you that we are losing eggs all the time. We've been losing eggs since we were a 20-week fetus. We went from 20 million to 4 million to 450,000 at puberty to 0 at menopause. So we are losing eggs every day. It doesn't matter if we're on, if we're before puberty. It doesn't matter if we're pregnant. It doesn't matter if, if we are on hormones that stop us from ovulating. We are always losing eggs. And so it is, it's again, very important. From the age factor is really important in terms of how many we have, but in terms of that testosterone treatment, we would have to temporarily pause the treatment so that we could wake up the ovary. Again, it's in hibernation mode. So we can wake up the ovary to make it give us eggs if we were doing IVF, or if you needed to, or if you wanted to do IUIs, so that we could get you back having a cycle, because it's this recruitment of the follicle, which requires the ovary to be awake and the brain to be talking to the ovary for us to go through that. And then ovulation, and then of course this half of the cycle where we can establish a pregnancy. So I hope I covered that fully, but yeah. So I don't worry as much, I guess, about the long-term consequence of testosterone so far in my practice. That's analogous to me as a long-term birth control pill. But on the other side of things, taking estrogen can definitely cause that factory of sperm to really shut down, and it can take up to a year to get it back running, and it may never fully recover. So never a bad idea to think about fertility preservation on the egg or the sperm side if you know you want to build a family. But I know a lot of people are transitioning pretty early in life before they're even thinking about kids. And so I want to reassure you that I think it's okay if you take testosterone and then put off the family stuff till later. Okay, so a couple more questions. Can you share the timeline start to finish for IVF? Yeah, sure. So the way we do it at CCRM, 99% of our patients are going to choose to do that genetic test. So we're not talking about what you may have heard is called a fresh transfer. A fresh transfer means I take you through your stimulation, I retrieve the eggs. Now your body goes into this half of the cycle, and we put back an embryo right into that lining when the hormones are absolutely wackadoo from that stimulation, okay? Estrogen's through the roof, progesterone's through the roof. this is not the best time to try to establish a pregnancy, and it puts you at risk for kind of the worst consequence of IVF, which is hyperstimulation syndrome. So that's a fresh transfer. So 99% of our patients are growing the embryos, freezing them, and then we come back in that frozen embryo transfer cycle. So while you could do fresh IVF and achieve a pregnancy within a 1 month period, so we would stimulate, get the eggs, make the embryos, put them back in, establish a pregnancy. So that would just be 1 month. At CCRM and a lot of centers that are, going more and more towards doing that genetic testing up front and freezing those embryos, it's going to take about 11 weeks, because it's going to take about 1 month to get to the point where we've retrieved the eggs, created the embryos, you're recovering. Then about 1 month to prepare the uterus, transfer the embryo, and do the pregnancy test. And then we build in a little bit of time for the genetic test result. And usually there's a little bit of treatment at the very beginning of IVF where we're kind of telling that brain, shh, don't talk. Oftentimes it's a birth control pill for about 2 weeks. So I always say about 11 weeks from the start of the birth control pill priming for IVF, through the IVF cycle, waiting for our genetic test, and then transferring that embryo. So I hope that helps. And the other thing I just realized I never explicitly said, but you may have figured out, because it's very similar to IUI. This same catheter that's thin and flexible, this is the same kind of catheter we use to put an embryo back in. So when we do an embryo transfer and we have that lining ready, we put the embryo in a droplet of fluid in the tip of this catheter, and using transabdominal guidance, so an ultrasound on the belly, watching the uterus, we can watch that catheter go into the cavity. We drop off the embryo, we sneak out. I always joke, I sprinkle you with pixie dust, and then 9 days later is that pregnancy test. That's how an embryo transfer works. It doesn't require anesthesia. It doesn't hurt. That's how that works. Very similar to the IUI. Is there a particular need for certain demographics of egg or sperm donors or carriers? No, it's what matters to the intended parents who are choosing that egg sperm donor. And then in terms of the gestational carrier, it's generically, the stuff that I mentioned about sort of the things we're looking for. So I would say there's not a particular need for demographics. It really is up to the intended parent what they're looking for. And for the carrier part, like who they connect with, you have to really trust this person. We're in the middle of a pandemic. They're going to be carrying your baby. So there's a lot of trust that's going to be need to be built between the intended parents and that carrier who's carrying precious cargo. Could you discuss endometriosis as it relates to getting pregnant by IUI? Yeah, so depending on the severity of the endometriosis, you may require IVF. We may find that your tubes are dysfunctional because of the endometriosis, and the HSG will help us understand that. Endometriosis, so for those who aren't familiar, this is what it looks like when it's on the ovary. This is what it looks like when it's in the pelvis, these little powder burn lesions. You can see one right there, and there's some little dots on this ovary, and there's some dots in the pelvis. So what is that? So there's they're endometrial glands, that's sort of that layer right at the bottom. That's what grows a uterine lining and sheds. And these glands can sometimes get into the wall of the uterus, look similar to fibroids. We call that adenomyosis. Adenomyosis makes your uterus kind of look globular, like the earth, like instead of being kind of pear-shaped, it starts looking like an apple. And it can cause painful, heavy periods. And then when those glands get not only go into the muscle, but get outside of the uterus, when it's outside the uterus, like this picture showing, we call that endometriosis. Same idea. You've got these little pieces of this tissue that is now growing and shedding a lining in a place it shouldn't. So whether that be in the uterine muscle or outside the uterine cavity in the pelvis, it's very painful. So pelvic pain is often a symptom. Pain during sex can be a symptom, especially with deep penetration, so certain positions. Those patients usually complain of very painful periods. And then sometimes we can see evidence on ultrasound if it's on the ovary and forms a special cyst called an endometrioma. But in general, the only way to diagnose endometriosis is with a surgery like a laparoscopy, where we stick a camera in the belly and actually look around the pelvis. Because it is causing you to bleed in places you shouldn't bleed, it causes inflammation. And whenever there's inflammation, you can have scar tissue form and damage occurred in normal tissue. And the fallopian tubes, it's not well represented by this image, but fallopian tubes are very delicate structures. They're very sensitive. Having gonorrhea, which can climb up the reproductive tract and infect the tube, that can cause long-term damage to a tube. Having chlamydia can do the same thing. Having your appendix rupture can do the same thing. Having endometriosis can do the same thing. Having diverticulitis, some young people are affected by diverticulitis. Anything in the pelvis that's going to cause inflammation can damage those fallopian tubes. And the best test we have to figure that out is HSG. But if the tube looks like it's working and it's normal, we may be able to get you pregnant with IUIs, but sometimes IVF is required. And why would IVF be the answer? Well, it's because we no longer need the tubes. And remember, I told you that there's about a 6 to 8 day journey in the fallopian tube, which is in that possibly inflammatory pelvis where that embryo has to get back to implant. And so for some people who have very severe endometriosis, we think that just kind of taking away that 6 to 8 days in the tube, not having that embryo have to deal with that inflammatory exposure, and instead having that happen in the lab and then just putting that embryo back into the uterus is enough to overcome the problem. It is possible, and I have had patients who had severe endometriosis and actually had a laparoscopy to clean up the endometriosis, and then their infertility was fixed and they were able to become pregnant. That's also possible. So surgery is an option, but in general, we don't have people rush to that because surgery is not without complications. And IVF is a great answer when you have endometriosis, but IUI could work. It just depends. Do you all partner with mental health professionals to support your patients through the emotional toll these processes can take? You may have mentioned this already. Yes. So we have a whole list of counselors that we work with that we can refer you to. There is definitely an emotional toll that comes with when you're trying to build your family, even if you don't have proven infertility. And in some cases, I think that it's even harder. I can tell you personally, there were a lot of tears in my house over the 6 months that both my wife and I took to achieve our pregnancies with inseminations with donor sperm. It is a roller coaster, up and down. You have hope, and then you have grief when the period comes, and then over and over and over again. And again, human reproduction is inefficient, so it probably won't work the first time. And you have to go into that with patience and understanding that that's kind of what this journey is going to look like. And if you get pregnant on the first one, we're going to high five and it's going to be awesome, but that's usually not the experience. So we do have mental health professionals that we work with. And I would also tell you that I view my job about 70% of my day-to-day is supporting my patients and just kind of talking them off the ledge because this is so emotionally hard. So we act as counselors too, but yes, we have a whole list of health professionals we work with. Okay, thank you for answering my question. I didn't word it very clearly. Do you find couples requesting certain demographics for donors or carriers? Oh, absolutely. In short supply, sorry. In short supply. We also have a 5-minute warning. So yes, so my minority patients do sometimes have a hard time finding the sperm donor they're looking for, the egg donor they're looking for, et cetera. And that's unfortunately kind of it. That is what it is. The sperm banks and egg banks are constantly trying to recruit a more diverse population to donate, but we do have limited supply when it comes to minority donors. And I have had patients who were unable to find, say, the minority donor they were looking for in the egg bank and had to do the fresh, the more expensive and more time-consuming process of finding that fresh egg donor that met the criteria they wanted. And agencies can certainly help you find these people who are willing to donate, who are more what you're looking for. But it is very challenging. And I on the sperm donor side, I give it like the feedback I've received from my patients is that the Zytex sperm bank, which is located down in Atlanta, in general has more minority donors than some of the others. Just so you know, if you're searching. No other questions. All right. Well, it's been so nice to talk to you, and I hope you learned a lot. And again, we'd be so happy to help you build your family here at CCRM Northern Virginia. I'd love to see you guys for a consult. But I hope you all have a wonderful day and a great conference. And thank you so much for having me.